Good afternoon. My lecture seems to be a subsequent follow-up to what Dr. Cabra has just spoken about, and realistic and hands-on approach to preterm and term neonatal pain management. So like we all are well aware, newborns, whether they're term or preterm, experience pain and have the right to receive safe, efficient, and effective pain relief. And there's a report out there which says, on average, a child admitted to the neonatal ICU undergoes an average of 14 painful procedures a day. And these could include anything from blood draws to feeding tube placements to blood tests or pinpricks, but there are up to 14 procedures at minimum a day. And this can have a short or a long-term consequence. The picture is actually of my child when she was in the NICU for 10 days, and I know to this day she has a heightened pain sensitivity because of all the procedures that happened while she was in the NICU. What are the developmental implications of pain? And this wonderful study by Taddeo in '97 did prove that infants exposed to a painful stimulus like a circumcision, which historically in the past was like, this is one of the most least painful, it can be done with just a local, or in the 1960s, there was no anesthesia. These patients had an exaggerated pain response even to a future stimulus, whether even it was just an immunization that happened 6 months later. And we can modulate this painful, exaggerated response with the application of EMLA or penile block. When do infants develop their neonatal pain receptors? And like Dr. Cabra said, even at up to 32 weeks, the first EEG is recorded at about 20 weeks, but the inhibitory pain mechanisms do not come into play till about 32 weeks. And why is this important for preterm babies? Because if they have a painful stimulus before 32 weeks, there is considerable amount of temporal summation and wind up because the inhibitory receptors are not yet fully developed. And these result not only in increased transmission, but also modulate long-term potentiation, and there's opioid receptor incoupling. So they have an exaggerated pain response, which is not surprising now. Hence, in conclusion, the pain receptors are functional after birth, but the pain produces significant physiologic and behavioral responses even in preterm and term neonates. There is mounting evidence of adverse effects on neurodevelopmental outcome. And we want to evaluate the impact of early life pain on analgesia, especially in preterm long neonates and those undergoing prolonged ICU care. Of course, there is always the genetic, environmental, social family factors, which also modulate the response. And there is persistent alterations in sensory function even after a non-painful or a mild stimulus in the preterm age group, and hence adequate management of pain is a goal of care for all age groups. And we want specific evaluation for efficacy and effects in early life because the response differs from that seen at older age groups. Commonly used pain assessment scales, and I looked a lot into this, and different countries, different parts of the world, different institutions, they all have their own specific pain assessment tools that they use. At Stanford, we use a FLAC scale for under 5 and 8 years. Then we use NPAS in the ICU. We use PIP in the premature ICU, and we use visual analog scale about the age 8. Everybody has their own scales, and they're all validated on their own end. The most commonly used is the FLAC scale, faces, legs, activity, cry, consolability. And since then, the revised pain scale has come through, and this is also being validated at this time. And the one in italics is the revisions to this. So initially, we used to say, if your child is difficult to console or comfort, maybe it's a pain score of 2. But it could be even pushing away the caregiver, resisting care, or comfort measures may also be an expression of pain. So where do we go from there? Most non-pharmacological strategies used in isolation do not completely help in treating pain, and we have to use non-pharm as well as pharmacological strategies to optimize comfort and minimize distress. I'm going to talk a little bit about all the non-pharmacological techniques that could be used in the ICU. Breastfeeding. Breastfeeding, when possible, for medically stable newborns during heel lancing, IM procedures, blood draws, effectively reduces pain. For breastfeeding to be effective as a pain management strategy, the infant must achieve an effective latch, sustained sucking, and swallowing for at least 5 minutes before a procedure. So if you know that every day this child is going to get a blood draw at 9 a.m. in the morning, you can have the child adequately NPO and have them start breastfeeding maybe 20 minutes before the anticipated blood draw so that the pain response is effectively modulated. Skin-to-skin care, kangaroo care. So what happens if the mother is not around? We can have the parent, another parent, the father, available for skin-to-skin care, kangaroo care. This again diminishes pain responses in term and preterm neonates and helps with their recovery. So the aim is this, that many of these painful procedures can be timed around the child's feeding, the child's sleep schedule, so that you can modulate the response as necessary. If both parents are not available, then non-nutritive sucking with a pacifier may be the way to go. It does help in regulating preterm newborn infants, and it reduces the procedural pain compared to not using anything at all. Swaddling, facilitated tucking. There is evidence that it can support pain response, reduce procedural pain in preterm infants, but in newborn infants, it's not very well validated. Multisensory stimulation, going on the gate principle of pain. You can distract the infant from pain, causing competition between a painful and a non-painful stimulus. And evidence against and for using oral sucrose, 24% is mounting. There is definitely value to decrease procedural pain in neonates. You can use it to start an IV in the operating room just before they're about to undergo any kind of start of anesthesia. Hence, environmental, behavioral, and non-farm measures are the first-line approach for minor procedures. Breastfeeding, skin-to-skin care effectively reduce procedural pain, and they should be facilitated when appropriate. And combination of measures could have the additive effects that you need. But this is just for minor procedures. What if there's a major procedure? Then we have to go to our armamentarium of systemic drug therapy. Of course, the dose that we choose depends on the drug pharmacodynamics and pharmacokinetics and the gestational age of the baby. We have a whole list of opioids that you can use for specific indications. First-line defense in most ICUs is morphine. There's fentanyl, methadone if the child is in consideration for being on long-term opioid use. We could use sedatives and anxiolytics as part of a multidisciplinary mode. Using one or more medications may help decrease the effective dose of each of them. There's always a role for IV acetaminophen, of suppositories that can be used for pain. We could use NSAIDs as appropriate. We could use ketorolac in small doses for a limited short duration. Ketamine, controversial under the age of 3 because of the potential role of neurotoxicity, but again, we weigh the risk versus benefits, and it could be a single dose maybe of benefit if needed in the NICU to put a child to sleep or to decrease pain. Of course, dexmedetomidine infusions, propofol infusions for sedation are of value for modulating the pain response. Local and regional blocks, we've been hearing a lot about this in this last 2 days. There is definitely a role for peripheral nerve blocks or caudal epidurals to be placed in, as needed for appropriate surgeries. Hence, adequate management of pain may be associated with decreased clinical complications, decreased mortality. Sedation, of course, does not provide pain relief. It may mask the neonate's response to pain. A lack of responses does not necessarily indicate a lack of pain. Before the age, 32 weeks of age, gestational age, just because the child does not create a pain response, it may be because their responses are still immature. Just because you do not get a change in heart rate or blood pressure does not mean that that neonate is not getting a pain response. So that needs to be definitely watched for. And in summary, pain in newborns is often undiagnosed and untreated. Compared with older age groups, neonates may experience a greater sensitivity to pain and are more susceptible to the long-term effects of painful stimulation. And we always want to consider using every method available, including environmental, behavioral, and pharmacological interventions to prevent, treat, or eliminate pain in all our clinical situations. Thank you.
Thank you.